This video will depict a right paramedian Abomasopexy in a sheep. This sheep is positioned in dorsal recumbency, and the ventral abdomen is prepared for aseptic surgery. This is being demonstrated with 3 preps of betadine scrub, followed by an alcohol rinse. Notice that the prep is started at the proposed site of incision, and then circular motions are made from the incision site outwardly. The proposed site of incision is indicated, and 4 corner draping is used to isolate the area. The proposed incision site is isolated with towels as demonstrated. The landmarks for this incision are the xiphoid, as indicated, the ventral midline, and the umbilicus. An area of about 10 centimeters should be draped for the proposed incision site. The towels are secured with penetrating towel clamps, and then the drapes are applied. Notice the way the drapes are folded. The point on the drape goes toward the surgical incision. The drape is unfolded, leaving one fold adjacent to the surgical site. The drapes are held in place with non-penetrating towel clamps. These non-penetrating instruments prolong the life of the drape by putting fewer holes in them, and hold the drapes in place on top of the towels. The surgeons rinse their gloves from any excess powder that might be present on the gloves that could irritate the surgical site. The proposed site of incision is indicated, about 2 centimeters caudal to the xiphoid and 2 centimeters to the right of ventral midline. A sharp incision is made through the skin with a scalpel blade. A number 10 or number 22 scalpel blade is appropriate for this incision. Note that this procedure is typically done in cattle, and in cattle the incision would be a hand's breadth from the xiphoid and a hand's breadth from the ventral midline, but in sheep the distances are much smaller. Hemostasis is controlled with hemostats and ligatures if necessary. The subcutaneous tissues and fat are also incised sharply, and it may be useful to sweep away the soft tissues from the external rectus sheath prior to incising this layer.
Thanks, Ann. Be over to operate over there eventually. That's the external rectus sheath, I think.
The external rectus sheath is incised carefully as shown. See, this nice fascial layer will be the holding layer when the body wall is closed. The external sheath is indicated, and the rectus muscle deep to the external sheath.
External rectus sheath, rectus muscle. Take these off. There's a stop.
The rectus muscle is incised with scissors, using them to incise the fibers along their length. This allows a visualization of the internal rectus sheath, which is being grasped with Adson forceps and tented and incised with Metzenbaum scissors. The incision is extended, and the surgeon is checking to be sure that they are through the peritoneum. That's the peritoneum that's elevated and incised, and again, checking to be sure the peritoneum has been incised. You'll feel the peritoneal surface is very slippery, and then the internal sheath and peritoneum incision is extended with scissors.
Great. Okay. So we'll take that. Yep. Get rid of that. Wonderful.
Once the abdomen is entered, the surgeon palpates for any adhesions or abnormal findings. The abomasum is identified and exteriorized.
Perfect, of course. Something's actually going right for me for once. So,
The pylorus is shown. Notice that the pylorus is where the lesser and greater omentum come together,
pylorus
and the cranial part of the duodenum goes off
and the lesser one.
from the pyloric part of the abomasum.
Just so they can see that nicely. Just palpate that so I can show that you're palpating it. Kind of can appreciate a little bit.
The pylorus itself can be felt as a thickening
That's
between
a big
the
valve, right?
abomasum and the cranial part of the duodenum.
Walk it forward. Lean this stuff back in. Go away.
The greater curvature of the abomasum is traced forward until the junction with the reticulum can be identified.
Hopefully we can show the reticulum.
Notice that you have to replace the pyloric part of the abomasum as you move forward to the reticulum. The reticulum is grasped and the junction between the reticulum and abomasum identified.
That's about as good as it's going to get. Okay. Then we're going to isolate this area of Abomasum. Going to hang on to that.
An Abomasopexy is performed a few centimeters away from the junction of the abomasum reticulum. This site is identified and penetrating towel clamps are placed to isolate the portion of abomasum to be included in the pexy. Notice that the mucosa is slipped prior to applying the penetrating towel clamps. This allows the surgeon to perform the pexy without perforating the lumen of the abomasum.
This one you just drop down. Take that up there just to start the line. So I'm going to start closing. She said that was fine, right?
Yeah.
And
Closure is started by incorporating the internal rectus sheath, the peritoneum, and in most instances we incorporate the rectus muscle as well. This is simply to prevent the internal rectus sheath from tearing. We use number 1 Vetafil, which is a multifilament non-absorbable suture to create an inflammatory response and
nice needle holders. How do I get
help
some lucky?
make a good adhesion between the abomasum and the body wall.
I'm going to take a couple bites. I usually have them without the Abomasum and reach around and get it. Hang on.
A few bites are taken to start the closure with just the internal rectus sheath, peritoneum, and rectus muscle. When the abomasum is to be incorporated, it is elevated, the mucosa is slipped away, and about a 1 centimeter bite is taken through the abomasum as the suture continues.
Kids usually talk to Karen. Sorry. Yeah, you can run with this hand. It'd be easier. Perfect.
So the internal rectus sheath and peritoneum are grasped, and then the abomasum, and then the other side of the internal sheath, peritoneum, and muscle. We try to incorporate at least 5 or 6 bites of the abomasum into this first layer of closure for the pexy, although theoretically 1 well-placed suture would be adequate to secure the abomasum to the ventral body wall. Notice that the needle is controlled at all times to be sure no other structure is inadvertently traumatized,
It calls fine.
and that the mucosa of the abomasum is slipped before every suture is placed.
One more bite, Patty, and then we'll let the other.
Notice that the external rectus sheath is not sutured, as this will be the next layer of closure and the layer responsible for holding the body wall together.
Yeah, it's right up on the. Just to make it look better. It would actually normally wouldn't work. I'm gonna fumble if I do it.
Notice when tying to a loop that it's appropriate to grasp each edge of the loop and pull it snug.
I've said that so many times. Your jaws. Remember what I'm showing, when I do the voiceover, but.
Following the pexy, the external rectus sheath is closed. In this case, we're using number 1 Vicryl,
You guys have a 7 lab this
a
afternoon?
multifilament absorbable suture with good handling characteristics. These knots should be pulled tight. There's very little soft tissue swelling that takes place. And again, these are the sutures that are responsible for the most body wall strength.
We don't need to get this whole closure on camera.
A simple continuous pattern is used on the external rectus sheath.
One view is showing the layer. You want to, I don't know, does it help you to cut
And notice that the forceps are used to stabilize the needle until the needle holders can be used to grasp the needle. Following closure of the external rectus sheath, the site is rinsed and subcutaneous tissues are closed
So we're going to get
with
a little bit of sub-Q, and then
a
we'll
2-aught absorbable suture.
skin, and then we'll
Again, a simple continuous pattern is appropriate.
only 2 today. And then we're set up for next Wednesday, Gary? For the cadaver stuff?
There are many ways to close subcutaneous tissues, and much of it is surgeon's preference. In this instance, the skin is grasped, retracted, to expose the subcutaneous tissues. And again, watch the forceps stabilizing the needle until it can be retrieved with the needle holders.
Just do a bit of skin and.
Following subcutaneous closure, the skin is opposed in a forward interlocking pattern or any other pattern that is acceptable. Surgeons can use simple continuous, forward interlocking, cruciate pattern. Any of these would be appropriate.